Hi, this is Dr. Mahadevan again, and we're going to conclude with how to read a chest radiograph. We're going to provide now expert analysis on these 5 challenging x-rays. So let's move forward and do that. So case 1, as you remember, is a 55-year-old woman with central chest pain, deep and boring, and also diaphoresis. Her ECG was normal, and we got a PA and lateral chest x-ray. And let's take a look. Here is our PA chest x-ray. And here is our lateral chest x-ray. And as I mentioned before, I wanted you to key in on the diaphragms because this is a really subtle x-ray. So what is the diagnosis? Did you get it right? Let's take a look here. If we look again closely at the diaphragms and blow them up, we can see something very, very subtle. And that is this thin rim of air that is seen right there. It's different from the stomach bubble. And then we'll take a look at the lateral. And again, I can show you this little thin rim of air there that is different, again, from the stomach bubble, which is seen here. So what is the diagnosis in this particular case? It's pneumoperitoneum. So this is a case of spontaneous pneumoperitoneum. That is when you see gas outside the bowel lumen. It should usually be within the bowel lumen, within the peritoneal cavity, but it has escaped. And what does this imply? That there's some spillage of the GI contents into the peritoneal cavity. And perforation with pneumoperitoneum is due to one of these two things, either a gastric or duodenal ulcer, in the vast majority of cases. And the rest of the cases are generally due to cecal perforation from a large bowel obstruction. So it's either going to be a gastric or duodenal ulcer most of the time, and then cecal perforation in the remainder of cases. And there are 2 clues to whether it's a gastric or duodenal ulcer or the cecum, and that is the amount of pneumoperitoneum. If you have a very scant or small amount of pneumoperitoneum, usually think about peptic ulcer disease or gastric ulcer. If you have a large amount of air seen on X-ray, then we think about things like cecal perforation. What do we see on plain film? When we're looking at the upright plain film, generally you're going to see air, as I mentioned, under the diaphragm, as in our case. And in an upright chest X-ray, you can see as little as 1 to 2 millimeters of air that might have escaped from perforation of a gastric or duodenal ulcer. We can also get a left lateral decubitus film, which might show air between the right lateral hepatic margin and the diaphragm. And you can also sometimes see air down in the right lower quadrant in the right iliac fossa. And on the left lateral decubitus film, we can see as little as 5 milliliters of air. You might ask yourself, why would you get a left lateral decubitus film if the upright film tends to be more sensitive and can detect as little as 1 to 2 milliliters of air? The reason is that some patients may have adhesions between their diaphragm and the liver, which is where this air tends to collect. And so you may not see anything there on the upright, but you might see some air collections on the left lateral decubitus. So let's look at some examples of pneumoperitoneum, spontaneous pneumoperitoneum, on our X-rays. And so here is an example. You can see again here under the left diaphragm some air or pneumoperitoneum, whereas under the right diaphragm it looks normal. One little hint or way of making the diagnosis is if you suspect that the patient might have pneumoperitoneum, is to get a lateral chest X-ray as well. And you can see here on this lateral chest X-ray this little crescent of air hiding underneath the diaphragm. And the reason to get the lateral chest X-ray is it's actually more sensitive than an erect posterior-anterior chest X-ray for the diagnosis of pneumoperitoneum. Here's another example of a lateral chest X-ray which shows pneumoperitoneum. You can see the arrow pointing out a small crescent of air sitting underneath the diaphragm, and that's abnormal. I mentioned to you before, if you see a tiny amount of air, we tend to suspect a gastric or peptic ulcer perforation as the cause of the pneumoperitoneum. But look at this patient. There is a large amount of air sitting underneath the diaphragms there. So what do you suspect is the cause of this? In this particular case, generally it's going to be, with that much air, a cecal perforation or large bowel perforation. Let's move on to case number 2. This is a 62-year-old male with a history of hypertension. He complains of chest pressure 10 out of 10, and he's treated with nitroglycerin spray 3 times, and yet his pain only improves to a 7 out of 10. A right internal jugular central venous catheter is placed, and we get a chest x-ray. So let's take a look at the chest x-ray. And here it is. And fortunately, today the radiologist is on duty and happens to provide an official read. So here's the official read by the radiologist. Right IJ catheter with tip at the caval atrial junction, tortuous aorta, low lung volumes, suggest clinical correlation. So here is that chest x-ray. And now the patient is developing shortness of breath and chest pain radiating to his back. So what is the diagnosis in this particular case? Were you able to figure it out? Well, if we look at this chest x-ray carefully, what we can see is this patient has 2 abnormalities. One is that the mediastinum is widened, and the second is the patient has a double aortic shadow. So if we blow up that aorta, we can see here is one aortic shadow coming down, and here is another right here. So what does that make us concerned about in this particular case? Absolutely, aortic dissection. And if we take a look at this CT scan of this patient, we can see that this patient has a type A aortic dissection that starts in the root of the aorta, and you can see that dissection continues to progress all the way through the arch and down through, all the way down to the patient's kidneys as seen here. So a type A aortic dissection. So as you can see, when we're trying to make the diagnosis of aortic dissection on plain films, the findings tend to be suggestive but not diagnostic. And there's a lot of them. So let's go through them one by one. The first is going to be widening of the aortic silhouette. And this is especially helpful if you have 2 chest x-rays, one that was done before and one from the day of interest. And what you'll look for is an interval increase in the diameter of that aortic silhouette. So if the diameter is getting larger, obviously, between the 2 chest x-rays that were taken at different time points, that's going to be a reason for concern. The other findings that you're going to look for are findings that we saw in our patient, one being widening of the mediastinum, and then the second being the double aortic knob sign. What are some other findings that we want to look for on a patient's chest x-ray when you're worried about aortic dissection? You're going to look for blurring or indistinct aortic margins, and then an abnormal aortic or mediastinal contour. So these are some things that you're going to look for. But there are even more findings. There's a whole host of them that we're going to look for on a chest x-ray. You're going to look for a disparity in the size of the descending and ascending aorta. You're going to look to see if there's an increased distance between the intimal calcification and the outer aortic wall. And generally, when we're looking for this abnormality, greater than 6 millimeters is abnormal between the intimal calcification and the outer aortic wall. So if this is where the calcification is on the inner aspect of the aorta, the intimal calcification, and we measure to the outer aortic wall and it's greater than 6 millimeters, obviously that is going to be concerning for an aortic dissection. Some other findings, you're going to look for a pleural effusion that's generally seen on the left side. You're going to look for rightward displacement of the trachea from the aortic dissection itself. and then depression of the left mainstem bronchus. So these are all of the findings that you might see in a person with an aortic dissection. And the reason that we're looking for all of these different things is we're trying to maximize the sensitivity of this X-ray for making the diagnosis. That's why we look for all these distinct entities. But unfortunately, it's not going to be abnormal in 100% of the cases. Unfortunately, it's only going to be abnormal in 60 to 90% of the cases. And making it even more challenging for us is some chest X-rays will be totally normal. So what do we need to do? We need to be able to recognize the abnormalities. Here's an example of an aortic dissection. And what do we see? We see some widening of that aortic silhouette, as seen right there. We see blurring or indistinct margins. So when we trace around the aortic knob, we see as we sort of get down to here that we lose the aortic margin. And then finally, if we were to draw in the left mainstem bronchus, as you can see, and then take it away, we can see that that left mainstem bronchus is being pushed down or depressed by the aortic dissection. Let's move on to case number 3. This is an elderly nursing home patient with a cough and worsening shortness of breath. She's intubated for a respiratory failure, and we get a post-intubation chest X-ray. And here it is. So what is the diagnosis? Well, there are several things. There is some patchy airspace disease that we see on both sides, and certainly concerning for pneumonia, but that isn't the life-threatening diagnosis that this particular patient has. What is it? Well, we can see that this patient has a lot of gas in their stomach, and that is abnormal. This patient also has air in their esophagus. You see that black stuff right there. That's also abnormal. We shouldn't see that. And then finally, if we draw the margins of the trachea and the carina, we see that the endotracheal tube right here does not lie within the trachea itself. So the diagnosis in this particular case is an esophageal intubation. So a chest X-ray can diagnose esophageal intubation. Certainly you want to try and diagnose it before you get the chest X-ray. You want to do it clinically or using end-tidal CO2 or pulse oximetry. And how does a chest X-ray diagnose esophageal intubation? If the tube is located in the lower esophagus, distal to the carina, that is concerning for esophageal intubation. If any part of the border of the tube is seen outside or lateral to the tracheobronchial tree, as in this particular chest X-ray, that makes you worried about esophageal intubation. And then when you see esophageal air, which we saw again right here, or gastric distension, again, we see pretty significant gastric distension, especially gastric distension with the presence of an NG tube or nasogastric tube. That is again concerning for esophageal intubation. And then finally, the least helpful finding, but one you should look for, is if there's noticeable deviation of the trachea caused by an overinflated cuff. So these are all the findings on plain films of an esophageal intubation. Let's take a look at some examples of esophageal intubation. Here is the trachea and the carina and the right and left mainstem bronchuses or bronchi. And you can see here is the endotracheal tube, the arrow pointing to it, and you can see it's clearly outside the margin of the trachea. So that is abnormal. And you can see as well a lot of air in the stomach. Another example of an esophageal intubation. Here is one of the margins of the endotracheal tube. And you can see if we draw in the margins of the trachea and both right and left mainstem bronchi, we can see that clearly it is outside the boundaries of these structures. So, and also we see an air-filled stomach. So these are all findings suggestive of esophageal intubation. Case number 4 is a 15-year-old helmeted male traveling at an unknown speed on a dirt motorbike. The crash is unwitnessed and handlebars strike his right chest. He complains of chest pain and shortness of breath, and his vital signs are 137/82, heart rate of 67, respiratory rate of 28, so it's a little bit high, and finally an O2 saturation on room air of 100%. And here is his chest x-ray, and as I mentioned before, the abnormality is not seen over his lung fields or his mediastinum or heart, it's actually to the periphery. So what was your diagnosis? Well, here is this patient's chest x-ray again, and if we blow up this area, we can see that there is some air, that black stuff, in the soft tissues. So we repeat the chest x-ray, now we're getting it upright, and it's clearer that there is air in the soft tissues, which is abnormal. Where did that air come from? In the case of a traumatic injury to the chest, the suspicion has to be that it came from a pneumothorax. And if we blow this up even more and draw this in, this boundary right here is the boundary of the lung. And I'm going to take it away now, and you can see the reason for that is this patient has a pneumothorax. And what we see is the boundary of the lung that doesn't make it out to the periphery. And the reason for that is because there is air trapped right here from the pneumothorax. And the only clue to it originally is this black stuff in the soft tissues, which is air in the soft tissues as a result of the pneumothorax. So what are the plain film findings in a pneumothorax? As I just showed you, you're going to see the visceral pleural line or edge of the lung without distal lung markings. And on the lateral, you can see this retrosternally or overlying the vertebra parallel to the chest wall. So here is an example of a visceral pleural line edge without distal lung markings. And it may be difficult to see on your screen, so I'm going to draw in that visceral pleural line and now take it away. And as you can see, there are no lung markings beyond that visceral pleural line right here, whereas if you were to look at the normal chest, you can see that the lung markings go out all the way to the periphery. And if we were to invert this x-ray, we can clearly see the lung right here. And as you can see, beyond that lung, there are no lung markings. So this is a pneumothorax. Case number 5, or our final case, is a 36-year-old helmeted male motorcyclist who ran into a car while making an illegal U-turn on a narrow 2-lane road and was thrown 30 feet. Another motorcyclist in his group is pronounced dead at the scene. Our patient had a loss of consciousness, and it now comes in diaphoretic or sweating, tachycardic, and confused, or with altered mental status. He has no chest pain or shortness of breath, and here is his chest x-ray. So, clearly an abnormal chest x-ray. What is your diagnosis? Well, if we look at this x-ray again carefully, we can see that there is widening of the mediastinum. There is tracheal deviation. You can see it's pushed over to your right. And then finally, there is a left apical cap, a collection of blood at the apex of the lung. And also, if you look at this lung field, you see that it's hazy compared with the right side. So this is very hazy. And the reason for that is that there is a hemothorax on that side. So this patient has a number of significant abnormal findings, but the wide mediastinum, the tracheal deviation, and the left apical cap, all suggestive of a very important diagnosis, and that is traumatic aortic injury. Supine chest x-ray, the classic teaching about supine chest x-ray that is that it's 90% sensitive and has a 95% negative predictive value for traumatic aortic injury. Unfortunately, it has poor specificity. So just because the chest x-ray is abnormal, it doesn't necessarily always correlate with an abnormality in the patient or on CT scan. So just because the patient's mediastinum may be wide on chest x-ray doesn't necessarily mean that they have an abnormality on their CT scan, such as mediastinal hemorrhage. So let's take a look at some examples of traumatic aortic injury on chest x-ray. And again, here's an example where we can see that the mediastinum is wide and that there's deviation of the trachea to the right. How do we confirm the diagnosis of traumatic aortic injury? There's two ways of doing it. The first is spiral CT angiography, and the second is echocardiography. And if we take a look at an example of a spiral CTA with 3D reconstructions, we can see this abnormality here is a traumatic aortic injury in 3D. This has been How to Read a Chest Radiograph discussion case with our expert analysis provided by Dr. Mahadevan. Thank you so much, Dr. Mahadevan, for joining us today and providing expert analysis. It's been great to be here today. Thank you so much.